welcome back my friends. So today we will learn about ventricular septal defect, VSD. Okay. First of all, ventricular septal defect is a cyanotic heart disease or acyanotic heart disease. Yeah, obviously it's a acyanotic heart disease. That is, there will be left to right shunt. From the left ventricle, the blood will flow or shunted towards the right ventricle. So it will be acyanotic heart disease. This we had discussed in the last lecture in detail. Okay, you can go through that lecture if you haven't seen it before. So VSD is a acyanotic heart disease we know, and it is the commonest congenital heart disease. Okay, it's a one liner you can say. Commonest congenital heart disease is the VSD. And embryology. Regarding the embryology, you should know a little bit, because I will give you a little brief about embryology so that it will be easy for you to understand pathophysiology of VSD. Okay, so in embryology, let me draw a diagram now. It's a simple diagram. I will draw only the lower portion of the heart. Consider this. This is the lower portion of the heart which develops into right and left ventricle. From the floor of the primitive ventricle, there will be a septal arising which is called as muscular septum. Okay, and you have somewhere here endocardial cushion. This is the endocardial cushion. From the endocardial cushion, another septum will descend downwards and fuse with this muscular septum. This is the membranous septum. Okay, so this is the muscular septum, muscular septum, and this is the membranous septum. So the muscular septum will arise from the floor of the primitive ventricle and it will ascend upwards. Okay, whereas from the endocardial cushion or endocardial bar, you can say, this is the endocardial cushion. I am drawing it here. This is the endocardial cushion, EC, endocardial cushion or endocardial bar. From this endocardial cushion, the membranous septum will arise and it will descend downwards to fuse with the muscular septum, and this together structure is called as interventricular septum. Okay, now you know the formation of interventricular septum. So suppose if this muscular septum, let me draw another diagram now. So this is the lower portion of the heart. The muscular septum is arising normally from the floor of the left ventricle and ascending above. But from the endocardial cushion, the membranous septum descends but not fusing with this muscular septum. That means it is not descending properly. So a gap is present, a potential gap is present between the muscular septum and the membranous septum. This gap is the interventricular defect, that is the VSD, ventricular septal defect. So by this gap or by this defect, the blood will shunt towards the right ventricle from the left ventricle. So the blood will go from here to here like this. So suppose this is the left and this is the right side. So from the left ventricle, the blood will get shunted towards the right ventricle. The membranous septum is not able to descend down properly, so that a potential gap is created between the muscular and the membranous septum that causes the blood to shunt from the left ventricle to the right ventricle. Okay, so now another possibility is, suppose this is the lower portion of the heart, and from the endocardial cushion, the membranous septum is descending down normally up to here. Okay, but the muscular septum, which should arise from the floor of the primitive ventricle, it will rise above this much only and it will come back. So it is not ascending proper, it is not ascending to a full extent to fuse with the membranous septum. So again a potential gap is created here between the muscular and the membranous septum, and the blood will get shunted from the left ventricle to the right ventricle. So this is also VSD. There are two main causes, that is either the muscular septum is not ascending up or the membranous septum is not descending below. Got it? So this is the formation of VSD. That is how the ventricular septal defect formation occurs. Now you can see here, yeah, this I had taken this from pediatrics book. Okay, basically you can see here the first diagram. The muscular septum is arising above normally and the membranous septum is descending below and getting fused. Totally it is getting fused. So it's a normal interventricular septum. But you can see in the B here, the muscular septum is arising above normally, but the membranous septum is not descending at all. So that is the cause of membranous VSD. You can see here it is the membranous VSD or high membranous VSD, or just you can say membranous VSD, in which the membranous septum is not descending properly. In the third diagram, the membranous septum is descending normally, but the muscular septum is not ascending properly or to a full extent to fuse with this. So potential gap is created here. So this is the muscular VSD. That means here the muscular septum is not ascending to a full extent. So this is the main cause of the formation of ventricular septal defect. Okay. So going to the next slide. Classification. What are the classification of ventricular septal defect? You can classify it based on the number, based on size, based on site, and based on the flow of the blood. So according to the number, VSD is classified as single VSD or multiple VSD. In single VSD there will be one defect, whereas in case of multiple VSD there will be multiple fenestrations, okay, by which the blood can be shunted. And according to this size, it will be small VSD, or it can be moderate VSD, or it can be large VSD. In small VSD, the size will be less than 0.5 centimeter square per meter square. It is easy, see, this is less than 0.5, whereas in case of moderate VSD it will be 0.5 to 1, and large will be greater than 1. So less than 0.5, 0.5 to 1, and greater than 1. These are the sizes of small, moderate, and large VSD respectively. Okay. So in case of small VSD, the size is so small that the blood flow will be restricted. That means the blood flow through this shunt is insignificant, whereas in case of large VSD, as the size of the defect is so large that the blood will easily get shunted towards the right ventricle. And according to this site, it is classified as membranous and muscular. In membranous, the membranous septum will not descend properly, and in case of muscular septal defect, muscular septum will not ascend properly. And according to the flow, VSD is divided into restrictive and non-restrictive type. As I said you before, restrictive, small VSD is also called as restrictive type. Okay, in small VSD, the shunt is so small that the blood flow through the shunt is obviously insignificant. So it's called restrictive VSD. Whereas in case of large VSD, it's a non-restrictive VSD. Here, the blood flow through the shunt will be large. Okay, so it is called as non-restrictive VSD. So according to the number, according to site, according to size, and according to flow, VSD are divided. It's an easy classification. You can read once and get remembered easily. Okay. So now next, going to our topic of interest today, that is the pathophysiology, or you can call it as hemodynamics. What happens here? Okay, in case of VSD. Let me draw a diagram now. Our diagrammatic representation starts now. Okay, as you know, I will draw this. This is the heart, and you have the 4 chambers. Let me draw here. Let me write here. This is the right atrium, and this is the left atrium. Here it's the right ventricle, and this is the left ventricle. And you have the pulmonary trunk here. This is PT, which goes to the lungs. This is the lungs, and here you have the aorta, that is aorta. Here the superior vena cava and the inferior vena cava will open into the right atrium. Here you have the pulmonary veins, 4 pulmonary veins, which opens into the left atrium, that collects the blood from the lungs, that is oxygenated blood. Okay, so this is the rough diagrammatic representation of the heart. Now there is a defect here, as you know. I will draw it in black color. Interventricular defect, either due to the muscular septal defect or it can be the membranous septal defect. There is a defect in the interventricular septum. Okay, now what happens? I will tell you the pathophysiology. Listen carefully. Okay, so the blood, that is deoxygenated blood from the upper half of the body, will enter the SVC, and the deoxygenated blood from the lower part of the body will enter the IVC. So this blood will enter now or is present in the right atrium. From the right atrium, right atrial kick occurs and the blood will pass to the right ventricle. So now all the blood is present in the right ventricle. Now the blood has 2 pathways. One, the blood can flow through the pulmonary trunk and go to the lungs. This is one pathway. Another one is the blood can flow through this interventricular septum and go to the left ventricle, that is through the shunt. But which pathway the blood will choose? That depends on the pressure gradient, right? So left ventricle pressure is high or the pulmonary trunk pressure is high. Obviously left ventricle pressure is very much higher when compared with the pulmonary trunk pressure. So where the blood will go? The blood will go directly from the higher pressure gradient to a lower pressure gradient, right? So the blood will prefer to flow through the pulmonary trunk, as the pulmonary trunk pressure is little bit lesser when compared with the left ventricular pressure. Okay, so from here it will not pass through the shunt. There will be no right to left shunting in VSD. Why? Because the pressure in the left ventricle is so high compared with the pulmonary trunk. So the blood in the right ventricle will prefer to flow through the pulmonary trunk rather than going to the left ventricle. Okay, so blood is going to the pulmonary trunk now and getting oxygenated in the lungs. So it is called as acyanotic heart disease because there will be no cyanosis in case of VSD. Now the blood will come from the lungs through the pulmonary veins and enters the left atrium. Now the blood is in the left atrium. Now the left atrial kick occurs, or the passive flow of blood occurs, and the blood will travel from the left atrium to the left ventricle. Now this much blood is present in the left ventricle. Again the question arises, when the left ventricle contracts, whether the blood will flow through the aorta or it will flow through the shunt. Where will it go? Again, it depends on the pressure gradient. Aorta pressure is high or the right ventricular pressure is high. Obviously, aorta pressure is very much high when compared with the right ventricular pressure. So, the blood will prefer to go to aorta or it will prefer to go to right ventricle. Obviously, it will prefer to go to the right ventricle as the pressure in the right ventricle is low compared to the aorta, right? So, the blood, that is the oxygenated blood from the left ventricle, it will go through the shunt into the left ventricle. That is the left to right shunt occurs in the VSD during systole. Okay, now this much amount of blood, that is the whole amount of blood which was present in the left ventricle or present in the right ventricle. Along with this, the deoxygenated blood also will come from the SVC and IVC and enter the RV, that is right ventricle. One question arises, whether here right ventricular hypertrophy will occur earlier or left ventricular hypertrophy will occur. Obviously you will think, see, there the blood from the left ventricle is entering the right ventricle and the deoxygenated blood is also coming from the SVC and IVC into the right ventricle. So the mixing of blood occurs in the right ventricle. Yeah, then the burden of the blood on the right ventricle increases and it should cause right ventricular hypertrophy. Yes, I am saying that left ventricular hypertrophy will occur earlier than right ventricular hypertrophy. Okay, now you will ask me why. How do I justify this? See, when the left ventricle contracts and push the blood, all the oxygenated blood into the right ventricle, at that particular time the right ventricle also is in contraction phase, right? So both the left ventricle and right ventricle contract simultaneously the systole. So what happens is the blood which was coming to the right ventricle from the left ventricle through this interventricular shunt will go directly into the pulmonary trunk. It will not lodge in the right ventricle. That means it will not stay in the right ventricle to produce burden on it causing hypertrophy. Can you get my point? Okay, so the blood which was entering the right ventricle from the left ventricle are not lodging in the right ventricle and they are directly passing into the pulmonary trunk, as the right ventricle is also in a contraction phase. It is not relaxing, right? So both the left ventricle and right ventricle are in contraction phase, though the blood will directly shift towards the pulmonary trunk without lodging in the right ventricle. Now this whole amount of blood, that is the oxygenated and the deoxygenated blood, will enter the pulmonary trunk and this will go to the lungs, gets oxygenated again and comes through the pulmonary veins, and this much amount of blood, that is oxygenated and the deoxygenated, are entering the left atrium. Left atrium will push all the blood into the left ventricle, so whole amount of blood again filled in the left ventricle. Now during the diastolic phase, where this blood is residing, that means where this much amount of blood is lodging, in the left ventricle or right ventricle? Obviously left ventricle, because all the blood has come through the pulmonary veins into the left ventricle during the diastolic phase. So the burden of the blood on the left ventricle increases, that causes it to become hypertrophy. So one thing to remember here, there is a left to right shunt, but left ventricular hypertrophy will occur earlier. First left ventricular hypertrophy, this all will undergo hypertrophy, and following this back pressure occurs in the left atrium. So left atrial hypertrophy also can occur up to a significant limit, right? Now, then after this, this pressure will be transferred to the pulmonary veins, there is pulmonary capillaries, and pulmonary vascular resistance will develop after that. And following the pulmonary vascular resistance, the right ventricle also will undergo hypertrophy. So you can see here, the right ventricle hypertrophy does not occur due to the burden of the blood, but it occurs due to left ventricular hypertrophy. Right ventricular hypertrophy is a result of left ventricular hypertrophy. Okay. So this is the concept you should know in the pathophysiology of VSD. Got it? Coming to the next point. Yeah, this is the pathophysiology. You can see here, right ventricular pressure is generally 1/5 of left ventricular pressure. Okay, and pressure gradient. In small VSD, it is also called as restrictive VSD, the shunt will be very much minimal to insignificant. Resistance is shown a lot so that the blood flow through the small shunt, if occurs, will produce a loud murmur. Okay, whereas in case of large VSD, which is a non-restrictive shunt, here the shunt will be maximum. Okay, it will be maximum, and that leads to left ventricular hypertrophy. You know this, the shunt occurs, it goes to the pulmonary trunk directly without lodging in the right ventricle, and it comes back into the left ventricle, and during the diastolic phase the blood in the left ventricle is more, so it causes a burden on the left ventricle, causing it to become hypertrophic. Right ventricular hypertrophy occurs, causes back pressure in the right atrium, which in turn causes the pulmonary vascular resistance. Okay, that leads to right ventricular hypertrophy at last, final stage. So the ultimate result is right ventricular hypertrophy, but initially left ventricular hypertrophy. Okay, so this is the pathophysiology or hemodynamics of ventricular septal defect you should know. Now you can see here, I have taken it from Google actually. Here there is a septal defect, you can visualize it. Let me select a black ink. Yeah, so this is the defect here, you can see I am encircling it. This is the defect, you know. So the red color is the oxygenated blood, right? So in the left ventricle you have the oxygenated blood, and here the deoxygenated blood is coming from the SVC and the IVC that enters the right atrium. So right atrium is full of deoxygenated blood and the left ventricle is full of oxygenated blood, and through this shunt the blood is traveling to the right ventricle and mixing with the deoxygenated blood, leading to the mixed blood. So this violet color which you are seeing is the mixed blood. Okay, this is the mixed blood, you can see here, violet color is the mixed blood. Okay, this is what happens here. Now coming to the final Eisenmenger syndrome, you know that this is the heart, 4 chambers, pulmonary artery, aorta. Okay, somewhere here you have this interventricular septal defect. Oh, what is this? Yeah, you have the interventricular septal defect. Okay, now what happens? You know that final stage of ventricular septal defect is right ventricular hypertrophy occurs. So what happens if the right ventricular hypertrophy occurs? The right ventricular hypertrophy causes the pressure of the right ventricle to get increased. Now when the blood is coming from the SVC and IVC into the right atrium, then into the right ventricle, the blood will flow through the shunt back into the left ventricle. Can you get my point? That means initially left to right shunt was occurring, but as the right ventricle hypertrophy occurs and right ventricular pressure increases greater than the left ventricular pressure, the blood will shunt from the right ventricle into the left ventricle. So this is the reversal of shunt, which is actually called as Eisenmenger syndrome. This topic I had discussed in detail in the last lecture. You can visualize it if you want. Okay. This is the Eisenmenger syndrome. You have the right ventricular hypertrophy. Here right to left shunt occurs and cyanosis develop. Here in this case delayed cyanosis. This is the concept of ventricular septal defect. And what are the clinical features? It's easy only. In case of small VSD there will be no significant shunting of the blood, so it will be asymptomatic. The patient or the child will be asymptomatic. Whereas in case of large VSD there will be delayed growth, because see, in case of large VSD more amount of the blood will flow from the left ventricle into the right ventricle and very less amount of blood will pass through the aorta and to the circulation. Okay, so the oxygenation of the tissues will be obviously hampered. That leads to the delayed growth, poor weight gain, and the nutrition, blood supply also is decreased, right? So that, and upper respiratory tract infection, and finally if the patient develops Eisenmenger syndrome, he will have the cyanosis and the clumping features. Okay, so, and one more thing, the investigation and the treatment part you will learn in medicine mostly. Here I am discussing mostly about pathology. So main pathophysiology and the hemodynamics part I had discussed in detail, so that you should know the concept behind that, you should know the reason behind it, but the investigation and the treatment part will be much dealt in the medicine. So just one sentence I had discussed here. So the characteristic murmur you will hear in case of VSD is pansystolic murmur. Okay, throughout the systole the blood is shunting from the left ventricle to right ventricle, so you will get this pansystolic murmur. And the treatment in case of small VSD, spontaneous closure may occur. There is a chance that spontaneous closure can occur due to adhesion of the muscular and the membranous septum spontaneously, so you can wait and watch for some time. Or in case of large VSD, you have to go for surgical closure by using Dacron patch, etc. Okay, that you no need to know now. So with this we had concluded the ventricular septal defect. Hopefully in the next class we will learn about atrial septal defect. Okay, it will be same like this only, little bit different, we will discuss in the next class. So with this, let me conclude our session now. Thank you so much.